Okay, so first of all, hi, we are Andras and Nina. We are also from the Mind and Brain Lab at the University of Ljubljana. And today we will talk about neuronavigation methods in the treatment of depression using transcranial magnetic stimulation, or in short, TMS. So in the first part, I will I will explain a bit about background on more sort of standard TMS targeting procedures. And in the second part, Andras will explain a bit more about the personalized neuronavigation methods based on neuroimaging. How do I move? Okay, so the first part is actually going to be a more sort of a short, condensed, and layman recap of Jura's presentation. So TMS has been recognized as a potential treatment for a variety of neurological and psychiatric disorders. It is already well established as a treatment for drug-resistant depression. However, its clinical efficacy is still rather modest, meaning that not all patients respond, and it shows a high variability in clinical responses. This is thought to be due to overly generalized treatment protocols that do not take into account patient-specific symptoms, nor their individual brain characteristics, such as brain anatomy and functions. This is why the field has been moving towards the direction of developing more sort of personalized TMS treatment protocols. What's that one? I can move it. Okay, it works out. Okay, so as we heard before, TMS is a non-invasive method that applies electromagnetic stimulation at the scalp, and in that way it either excites or inhibits neural cells in brain areas that are thought to have abnormal activity. So when we talk about personalized TMS protocols, it is important to have in mind that there is a large parameter space, meaning there are a lot of parameters that we can change, adapt, tweak to each individual. For example, some of these parameters are call position, call orientation, stimulation frequency, stimulation intensity, and so on. So within our research group, we are mostly focused on determining the optimal call position. So as you've heard before, this is actually identifying the location on the scalp that would result in the highest clinical efficacy when stimulated with TMS. So most common TMS treatments so far have determined the optimal call position based on the known neuropathology that needs to be treated. So for example, in depression, most, if not all, TMS treatment protocols target the dorsolateral prefrontal cortex. This is due to different studies that show that this area plays an important role in depression. So for example, the most established protocol, as you explained, is a repeated high-frequency stimulation of the left dorsolateral prefrontal cortex, which actually excites this part of the area. However, in recent years, it has been suggested that it has been recognized that psychiatric disorders are disorders of actually brain networks, not individual brain areas. So when we perform this TMS stimulation, it is assumed that we do not stimulate only one specific individual brain area, but actually a more sort of wide, these stimulation effects are propagated throughout a wider distributed brain network. In depression, one of the functional connections that is often described is this anti-correlation between the dorsolateral prefrontal cortex and the subgeneral anterior cingulate cortex, which is a deep brain area thought to be involved in regulating emotions. As I said, most, if not all, TMS protocols target the dorsolateral prefrontal cortex, although we do not really know if this is the only target that would be important in treating depression, and not even if it's the most important one. But most of the procedures that I will explain now target the dorsolateral prefrontal cortex. So to date, most studies have used this so-called standard procedure. In this standard procedure, you first identify the hand motor hotspot, which is a brain area in the motor cortex, which you can identify using TMS stimulation, and then you move 5 centimeters forward, anterior, and you should reach the dorsolateral prefrontal cortex. So this is the most commonly used method. However, of course, it's an approximation. It does not take into account brain size and brain shape. This is why a lot of different other methods have been suggested. One method that is often described in literature is targeting based on the 10-20 EEG system. So here, the dorsolateral prefrontal cortex is thought to be localized at the electrodes F3 and F4 on different sides of the brain. So this method does, to some extent, take into account brain size and brain shape. However, it's still not that precise. So to get anatomically the most precise location of the dorsolateral prefrontal cortex, it's best to use the structural magnetic resonance imaging, which has very high spatial resolution. So a lot of studies have tried that, and they usually identify the dorsolateral prefrontal cortex at the Brodmann areas 9 and 46. However, as we said before, depression is recognized as a disorder of brain networks, not individual brain areas. So we are not so much interested in determining just one specific brain area, but identifying a larger brain network that seems to be involved in this neuropathology. And for that purpose, we need functional magnetic resonance imaging, which is usually collected during resting state. So using this fMRI data, we can then calculate functional connectivities between different parts of the brain, and in that way identify specific brain networks. So obviously the more advanced neuroimaging methods give more detailed information. So the idea would be not to use this method separately, individually, but to combine them, which would result in multimodal neuronavigation. So here we could use the anatomical MRI to determine anatomical brain characteristics, to identify the specific anatomical locations. Then we could use diffusion-weighted MRI to identify structural connections, white matter tracks, which seem to be important in TMS treatment. And then we would, of course, use functional magnetic resonance imaging to identify the brain networks. Okay, so this is from my part, and Andras will explain about personalized neuronavigation.
So, yeah, as Jure said, we have only 50% response rate for depression, which is still quite good considering that we're talking about treatment-resistant depression. But now the question is, can we improve that? And more precisely, can we improve that by using neuroimaging? Now, there is a field within neuroscience or psychiatry which is called precision neuroscience or precision psychiatry or precision fMRI if we're using fMRI. And the aim of this subfield is to develop clinically relevant measures. And clinically relevant measures should be reliable, stable cross context, and sensitive to idiosyncratic features that may be clinically relevant. Now, the question is, are these features, is functional connectivity potentially clinically relevant? And the answer is yes for 3 reasons. First, functional connectivity is a reliable measure. Here it is important that it is reliable if only if we gather enough data. For example, 10 or 15 years ago, we used to record about 10 minutes of resting state. Now we know that this is not enough. at least it is not enough for precision neuroscience. It is not enough if you are interested in this network assignment at the level of an individual. So we would need about 45 minutes of resting state data for cortical regions, if you are interested in that. But if you are interested in subcortical regions, which are also important in depression, we would need 90 minutes of data. And we may need even more if we were interested in some other derived measures. And the other question is, what does functional connectivity represent? So let's say we measure the same person multiple times. We will get a bit different results every time we measure a person. But still, if we gather enough data, we see that most of the variability in functional connectivity can be attributed to between-subject differences. So only a small part, less than 5%, can be attributed to within-subject variability, so to variability across sessions. So functional connectivity is a trait-like property. So it does, of course, changes with thoughts, so it changes with what you're doing in the scanner, even with tasks, but these changes are relatively small. Functional connectivity mostly, at least this is one explanation, that functional connectivity mostly represents homeostatic processes and history of co-activations. And the third property of functional connectivity in the resting state is that it varies a lot across people. So here we see network assignment based on resting state functional connectivity from 10 people. And we see that these people are all similar to each other, but they also differ a lot. And so if we would base our target in TMS based on group average, we lose a lot of information if we only use that. And we can see that here. So if we use group average, here all people have the same, I mean, this is a simulation. If we would target the same area in all of these people, we see that we target very different networks. We usually, I mean, in depression, we aim to target DLPFC, which is a part of frontoparietal network, but we see that in some people we don't even target frontoparietal network, rather we target other networks, neighboring networks. So this might be one reason why we don't get good results in some people. Okay, now the question is, can we improve that? And as Jure has said, clinical efficiency of TMS treatment in depression is related to negative correlation between subgenual cingulate cortex and DLPFC. And then the question was, can we improve that by considering the optimal target? And in two retrospective trials, they showed that if we compute the optimal target and then the difference between the optimal and the actual target, we see that when this difference was smaller, the clinical improvement in depression was also greater. But this was based on retrospective trials, and we still need large prospective trials which would compare personalized and non-personalized protocols to see how much of an improvement would we actually get. So yeah, this is where we're currently with TMS treatment.